Hi, I'm Josh McDonald.
And I'm Miranda Materi, and we are Hand Therapy Academy.
We're going to talk today about pillar pain as a complication after carpal tunnel release and some of the symptoms, maybe what we do for it. So, Miranda, what is pillar pain?
We know carpal tunnel release procedures are one of the most common procedures formed in the United States, that is, anyways. Um, Pillar pain is basically a pain that occurs after carpal tunnel. We don't really know why it occurs, but it's like a hypersensitive, really tender pain in usually in the hypothenar and the thenar eminence, like kind of around the borders of where that transverse carpal ligament attaches from. Um, and so it usually is basically where you can't put weight through your hand. It can last up for 9 months. You're kind of like, what the heck's going on? Why'd I even have this surgery? Um, but usually it's something that will go away. It's just something that is very poorly understood by the medical community. Like, why does it occur? Who's more likely to get it? We don't know those factors. There's things that you can do to reduce it. Like I think there's a paper that was published, it's probably been like 7, 8 years ago, where they were saying if you take an alpha lipoic prior to the surgery, which is a natural supplement you can get over the counter, if you take that prior to surgery, it can reduce the likelihood of developing pillar pain. That's one thing you can do prophylactically. But what do you do after you have a patient that does have pillar pain, or what are you telling your patients that have pillar pain?
Yeah, first off, we try to talk down the frustration because a lot of times, like you said, patients are like, why did I have the surgery? This is almost worse. And so we say, listen, this is a kind of a fluky thing. It's rare. It doesn't happen a ton. It's just unfortunate, but let's work on getting you out of it. So some of it's kind of like talking them down. They'll get really frustrated with the surgeon, say the surgeon did a bad job. And like, that's not necessarily even how that works. We try to do a lot of like scar management stuff, all assuming the wound from the surgery and procedure is stable and closed and ready for it. We try to do a lot of that cross friction massage. We try to do some of the more surface level scar management stuff, even like the silicone gel sheeting and some of that stuff. Even though that's not going to help our scar below the surface, it's still useful for softening that bulk and density that is on the outer epidermis.
Yeah, I think those are very helpful techniques. And I think the other thing that's kind of weird with these patients too that I thought of when you're talking is that they could have one side done and it'd be perfectly fine, and then do the other side and get the pain on that side. And they say like, well, is it because of the inflammation around it? Is because the nerve is having a hyperactive response? We just really don't know.
Yeah, yeah. Um,
So
I'm also a big fan of like myofascial release efforts to that area for a lot of different diagnoses, but for that as well. And so whether it's doing some work with like a tennis ball, something soft and forgiving, and doing some like loading through that as like tennis ball on a towel at the table, hand on the tennis ball, very very lightly, and then they get to decide how much load to add to help break up some of that adhesion. Even like stretching and some of the normal like wrist extension stretching stuff just to kind of break up the fascial adhesions that are happening in there, that everything's tightening around it, maybe as a part of the diagnosis, maybe secondarily, but trying to keep that from just getting junkier and junkier.
yeah, that's very helpful. And I'm gonna go ahead and put a dirty word out there. Sometimes I like to use ultrasound for this.
What? You are not
I
allowed to
know, I
say
know.
that. I know.
I know, no one likes it when we talk about ultrasound, but I feel like this is one thing that it actually helps with.
Yeah, yeah.
And
And
I know everyone's gonna be like, "There's no research supporting it." I know, but it takes, like, 3 or 4 minutes, and I do think it helps a little bit.
yeah, yeah. I cannot remember the last time I pulled out my ultrasound machine, but there are some diagnoses that I don't get often. That is, if it works and it makes patients feel better, there's no problem with pulling it out. And to the people that are triggered, and I'll call triggered, anytime we mention the name ultrasound, sometimes honestly, we just let a post happen with ultrasound just because there's so much triggering. The post looks like it does great on the Instagram algorithm, but think about how many things we do that don't have research around them. There's no research that says ball rolling is great for wrist mobility. There's no research that says that the three-way wrist is great for strengthening. But we know those things exist, so it's okay to do some things that maybe have the experiential benefit, but not the actual like research side because they still make patients
Right,
feel
and
better.
yeah, and your expert opinion, right? That's like a
Yeah.
level 5, so it's at the bottom of the pyramid, but I do think, um, and if the patient doesn't like it, so what? You don't do it again. It's pretty harmless.
Yeah. Yeah. IA stim is another one. Again, is there a ton of research out there? Not yet. Negative pressure IA stim or cupping. Again, something with not a ton of research out there on it. And that's another one that people get triggered about and like, oh, I can't believe you guys do research based stuff. You shouldn't be mentioning cupping. Just because there isn't research yet or because it's not supporting the research doesn't mean patients don't feel better with it. So I actually like doing cupping over on most of my carpal tunnel release patients that are still having some pain and stiffness. I like doing it over that area because it really is this decompressive load, and patients say that feels great. So yeah, we do that a bunch.
Yeah, definitely agree with those.
Yeah, yeah. So there's only so much we can do for pillar pain: range of motion, working scar tissue, maybe some myofascial stuff, fascial connective tissue, all those things. If you guys have ideas, if there's something that you just love for doing with that population, let us know in the comments below. Or you can reach us at on our social media platforms, Hand Therapy Academy, or info@handtherapyacademy.com.